So today we've got joining us Associate Professor Mehdi Valizadeh. Did I get that right? I think that sounds about right. He's a specialist periodontist and principal at Vision Periodontics in South Perth. He's also an associate professor at the University of Western Australia, where he supervises the Postgrad residents, and he is currently serving as the federal president of the Australian Society of Periodontology. So thanks for joining us, Mehdi. I know you're a busy guy. We spoke about doing this a while ago, but it was tricky to find a time that fit in with both our schedules. But I used to see quite a lot of you. I feel like I've not seen you for a long time. We used to cross paths quite a lot. We were both involved in the previous Bupa network and before that Dental Corporation, and we shared many drinks, beers, chats at conferences. But we've obviously both now got our own practices, so it's good to see you again. It's always good to chat. I wanted to just delve a little bit into your background. I think one thing we've both got in common is we're both immigrants to this beautiful country that we now call home. You're originally from Iran. What was life like back in Iran, and what sort of led you into dentistry?
Dave, first of all, thank you for having me.
Pleasure.
And we should get together more. Life was different, huh? Life was different, not because we were living in completely different country, but we were younger. We didn't have kids, and life was not as complex as is now, huh? Perhaps that's one of the reasons we don't get to see each other much. In terms of dentistry, I always say dentistry is the same. What we do is the same, but the demographic variations is one aspect of it. And yes, migration is a major phenomenon which happens to you technically. So whether it's when you're moving to a country, it's similar to yours, is an English-speaking country, or it's not the language. It's that everything is different.
Yeah,
and it takes a long time for you to adapt and get to know the variations, especially in our job, to see those demographic variations that we get to see. It's interesting. Speaking to my friends back in Iran, it's been a while, but if you take me back there, I would have the same challenges with readapting myself and perhaps practicing in that environment. Yes, I think we have been lucky, and it's a beautiful part of the world that we are living in. We have our own challenges, day-to-day challenges. I always say in our line of job, wherever you live, it's a high-pressure job.
Yeah, certainly.
It's with a lot of stress, but definitely we are fortunate living here, yes.
And what sort of got you into Perio as such? Because obviously I think you worked as a general dentist for quite some time in Iran, and then you decided to go down the specialist pathway. What sort of drove you to do that?
Funnily, maybe I shouldn't say that. I was a implant practicing dentist, so I starting doing oral surgery and implants, and I didn't really have a good understanding of periodontics.
Mm-hmm.
So technically, starting placing implants and being involved more in oral surgery, I felt like I need to get to pursue this in a more official way. And when I started my official training in periodontics, I realized, gosh, this is a completely different ballgame.
Yeah.
So that's how I got involved with the periodontics, and I'm very happy that it opened my eyes in a different way to what I do today.
you obviously made the decision, as I did, to move to Australia. It was a big decision for me. Obviously, probably a little bit easier for me with the English connection and the Commonwealth, if you like. But for yourself, what did that look like? How difficult did you find the move?
It is difficult. It is challenging. It's difficult. I think we were lucky in a sense that Australia didn't make it easy for us to move. Meaning we started sitting we should have sat the ADC exams. And I always say that's a good side of ADC exams than being a drawback, which you can travel to Australia, sit exams, and travel back to your country, continue practicing, etc. So, and I did have some academic connections with Australia as well, meaning the process was almost a gradual process.
Yep.
So it was a process that started in 2008, and we permanently moved in 2013. Yet, I would say the first 3, 4, 5 years was the adaptive years.
Yeah.
Just getting to know how things work, how the codings, the item numbers, the culture, your conversation with patients completely differ because of the cultural differences. And yes, that's it. That's something that it eases with time.
Yeah.
And then after a while, suddenly you feel like, oh, this is home, and you feel comfortable about it.
Yeah, yeah. I think we've employed quite a lot of overseas dentists, and I think the skill level is often the same, and you know they're obviously they've sat the exam, so they're qualified to come here. But it's the communication with the patients is what they struggle with.
Yes.
It's certainly some cultures, when they come here, they're quite stiff and uptight, and that they're the doctor, there's the patient, and that doesn't always work well in the Aussie culture.
Yes,
it's you kind of have to soften your approach a little bit.
I love it. Yeah. So when you initially get struck with the fact that they don't call you doctor, they call you and yes, and it's completely different. If someone calls you doctor, you will feel completely uncomfortable.
Yeah. It's a very relaxed consultation process.
Yes.
And you came in. Obviously, you came in as a specialist. Was it quite difficult getting that specialist recognition here as well as the ADC exams?
Yeah. In Australia, they wouldn't look at your qualifications as specialist unless you get registered as the general dentist through the exams.
Yeah.
And then they take you to a assessment process, which is quite vigorous process. It takes mine at least took 2 years time.
Yeah.
Yeah.
And your wife's a dentist as well, I think.
She is a dentist. That was the other dilemma for us, because initially we thought, okay, what's going to happen if one passes, the other one doesn't? So, and the other dilemma was, I was a periodontist. I'm not a good dentist, and that was the second dilemma for us. But luckily, everything worked for us.
Yeah. And that was 2013, I think you came up.
This is 2013 when we came, but at that time, my wife Leila, she was still busy with the exams.
Mm-hmm.
I started working here, but she eventually passed the exams and she started practicing as well.
Great. And obviously, if you actually look at your achievements, it's some achievement to not only establish yourself, but now the positions you hold. So, which kind of leads me on to my next chat, is your involvement with the university, the involvement with teaching. You're obviously now a professor at UWA. You're teaching the next generation of periodontists. How do you find that? Is that a passion of yours as well as daily practice?
I think I'm coming from an academic family. It's generally speaking, if you'll let me go somewhere, you'll find me somewhere academic.
Yep.
more or less. I did used to do this back in Iran. Here, when the opportunity came up, I was invited. To be honest with you, and you're very much involved with teaching. Teaching is very good for your self-development.
Yep.
Makes you more disciplined, and you document more, you read more, you study more, especially with the younger generation. When you see some bright, smart people, it just immediately humbles you. And you say, and this is a daily practice for us. So I always say, success in our line of job is rented. And if you really take it for granted, in a couple of months you will be seeing that it's just fading away. So you should be consistent. And the teaching has always helped me in that sense. I also believe that in our community, you need to give back to the community as well. So that clinical position I have got at UWA helps me with that. And I do think I'm very lucky because technically I'm dealing with DCD students. DCD students are generally more enthusiastic about what they're doing. They know why they are there, and they really want to absorb things. And this interaction really helps myself and them with growing.
Yeah, it's much easier teaching people that really want to be there.
Of course.
And how are you finding the newer generation? Obviously, how is the way they learn, is the way you teach them different than you learn?
Yes.
In what way?
That's a tricky question to answer. I would say they are very smart, but they are very different.
Mm-hmm.
They are hardworking. Our generation is hardworking as well, but their definition of hardworking is different than ours. So that's another challenge, that when you're dealing with different levels of enthusiasm, skills, knowledge, you need to analyze how to deal with each of these personalities. I'm convinced that our generation is very different than the newer generations.
Yeah, I think what I've found is maybe we had to go searching for the information a bit harder. So there's kind of, I don't know, there's maybe a little bit of an expectation that the information is just given to them without pre-planning or without preparation sometimes.
I'm not sure if it's good or bad, because these days when you ask them to prepare a PowerPoint or a presentation on a certain subject, they can do it in 5 minutes.
Yeah.
Using AI cloud.
Yeah.
We used to do this for weeks.
Days and weeks.
Yeah. So I'm not sure if this is good or bad. It saves a lot of time. If they're using this time to learn more, then that's a good thing.
Yeah.
If not, no.
Yeah, I mean the AI stuff is I mean, I was been using it this morning to help write patient notes and patient letters, and it saves me hours and hours.
Yes.
But it is worrying to think what that impact that's going to have on the human brain, I suppose.
Yes. The learning process, because learning is a process.
Yeah.
Yeah.
Yeah. And with all these, also mention you obviously the current position of Federal President of the Australian Periodontist Society. How did you end up with that position, and what's your role there been like?
That was I would say still I'm getting close to the end of my tenure with the ASP Federal Presidency. Still, for me, I feel privileged I ran the ASP. Australian Society of Periodontology has got state branches. So I ran WA's state branch. Normally it's 2 years, but I ran it for 3 years because it was COVID years, etc. And once I finished with my state presidency, I was approached by some senior members of the ASP if I'm interested in this role. I did know about the role, but once you step into it, then you realize there's more involved. Still, I'm very happy. I felt honored because of the trust. And the mission of ASP is different than our academy, which is only for periodontists. ASP's mission is to give awareness in terms of the periodontics in the society, and also to develop and progress periodontics in the dental community. So whether you're a hygienist, oral health therapist, a dentist, or a dental specialist, you can be part of ASP.
Excellent. With all these roles, you've got your private practice as well. You have 2 young children, I think similar age to mine. You got a boy who's 10 and girl who's 7. Is that right? Yeah. So I think I'm 9 and 6.
You have 2 daughters.
2 girls. Yeah. I think we used to compare tiredness notes in the earlier days when we were at conferences, and and sometimes the flights to those conferences were our time to rest.
Yes.
But obviously, getting a little bit easier with the kids, as I'm sure yours are.
Of course, yeah.
Well, different issues.
Yeah.
How do you juggle it all? Because I think it's a question I like to ask other people like yourself, just for awareness, but also from personal advice as well, because I think it's a balance I always struggle with a little bit.
I'm hoping my wife wouldn't listen to this podcast, because Leila really takes a lot of kids-related responsibilities, so it actually requires a lot of sacrifice.
Yeah.
In terms of how to juggle this, I'm pretty sure that you're much better than me, so I don't feel like I'm in the position of giving any advice. But once I asked a very successful friend of mine that how you juggle things. And he confidently said, it's all about time, and it's time management. So I think the more disciplined you are, I don't know how disciplined I am, the more you can juggle in. But at the same time, you need to look after yourself to be able to be consistent as well.
Yeah.
But I have a joke, to be honest with you. When people ask me for something, they say, do you have time? I say, I'm always free. That helps.
That helps, yeah. I struggle. At times I'm on top of it, and then there's times where I'm kind of like, no, I'm a bit overloaded right now, and it's a constant battle, because you want to have that family time, but you also want to, I think most of the people I speak to are still very ambitious, very driven to succeed and do new things, which we all are. And whenever I have a spare block of time come up in my day or week, I seem to very, very quickly fill it with something.
I agree. I agree.
But I think that's also how that's also how people like us tick. That's kind of, we're never going to change. I don't think we'll ever see us on a sun lounger for too long,
I don't think so. So, yeah. Some people try to change us, but it didn't happen. 2 things I think works against us as well. There are 2 things. I'm not sure if you've been conscious about it. I'm pretty sure you've thought about it. Number 1 is, for whatever reason, I feel like in Australia, the days are shorter. The 24 hours in other parts of the world are longer. I've tried to explain this to some Aussie and non-Aussie friends. Some people agree, some others don't. The second thing is where we are situated. So technically, with all our travels, etc., we spend a lot of time en route.
Yep.
And that adds to physical pressure as well.
Yeah.
Just comparing yourself, imagine yourself having the same career, but living in UK.
Yeah. Yeah, it's very easy to travel around.
Yes.
Yeah.
Yes.
Because yourself, you've just literally just flown in from Spain, was
Spain,
it?
yeah.
And then week before you were in
New Zealand.
New Zealand.
Yeah.
And
2 weeks before that, I was in Vienna. So.
And were all these courses that you were running?
They're either courses or my institutional commitments.
Yeah.
Or lectures and conferences.
Yeah.
Yes. So they are. I would say yes. They have the same nature. Yes.
Yeah.
Yes.
So yeah, well done for getting straight off a plane and coming in and giving up your spare time to chat to me. So.
Yeah, it's a pleasure. I'm having a good time actually.
Let me just find out what I wanted to actually delve into some topics now with you being a specialist. I've interviewed a few different specialists, and I think as a general dentist, we don't always know what the specialists do all day. We think the prosthodontists are doing full mouth rehabs all day, and they're not. Yourself, you've got Vision Periodontics in South Perth. What's your balance of work between Perio, saving teeth, versus the implant stuff at the moment?
I would say majority of my job is Perio.
Mm-hmm.
And the Perio is a range of non-surgical, surgical, regenerative, and also mucogingival surgeries. So that's why maybe 50 to 70% of the treatments involved are periodontal treatments. The remaining are implant treatments, whether it's complications associated with implants or the planning and placement of the implants.
And with your perio stuff, I think I'm in a very different practice, see a different demographic, doing a lot of all-on-4. We get a lot of patients who don't want to save their teeth, and we actually spend a lot of our week trying to persuade people to save their teeth.
Yep.
Are you finding that you tend to get a more motivated cohort of people because they're actually choosing to come to see you? How do you keep them motivated? Because perio, let's be honest, it's a hard sell.
Yes.
It's painful sometimes. Yeah. It's you don't always see an immediate benefit. You don't always see a cosmetic improvement. So I always think it is quite a hard sell to patients.
Yep. I think I would say the patient who you already mentioned that the patient who attend the practice because they've already discussed this with their dentist, they have some knowledge about what's happening, or there has been some resistance to come and see us, but eventually they've decided to come. In that sense, they are biased.
Yeah.
So it's when the patient comes to me, and in terms of the specialty, and you were talking about some differences between a specialist practice and a general practice, I always get to say it's easier in specialist practice because most of the time the dentist has done the good job with speaking to patient. An initial screening has already been done.
Yeah.
And then when the patient comes, the second part is we do talk about, I wouldn't say the majority of peri patients, but some peri patients are skeptical about whether going through the implant rehabilitation, full mouth implant rehabilitation, or period. There are a lot of factors. It's not just it's the financial factors, aesthetic factors, long-term factors, etc. But we always talk about with those patients about the survival rate of teeth versus the survival rate of implants. And it's easier for me to, as a practitioner, to deal with teeth and try to keep them than in long-term dealing with the implant-related complications.
Yeah, yeah. We're certainly finding a massive increase in the people that just want to come, have all their teeth out, get a quick fix, get implants. And we have very upfront and frank conversations with these people. Say, hey, look, you could keep your teeth for many, many years. But if you have complications around these implants, it's a much, much harder thing to manage.
But to be honest with you, from a human psychology perspective, that's something that you can understand. So you can't really blame them for. But from a human psychology perspective, you just want to achieve the short-term benefits.
Yeah. We don't often think about
the long term, and you think in long term you don't belong to the cohort that will come up with some problems.
Yeah, correct. And mixing perio with implants. This question actually came up at a study club that we ran last week, and we actually had a periodontist in the study club. Bit of controversy. Implants and probing. Okay, so actually probing around dental implants as a monitoring point of view, and we're talking, say we're talking healthy implants here. Should people be just probing to monitor around implants or leaving things well alone?
This has been argued a lot.
Yeah.
And not verbally, but in the literature. So just recently, EFP, or European Federation of Periodontology, which ASP is affiliated with the EFP, has published a guideline. And this guideline is based on the best scientific evidence available till now. Yes, we do need to probe. What happens is when you place the implant and then load it, the maintenance starts. And when the maintenance starts, you enroll your patient in a program, whether it's I'm not talking about some erratic patient, non-erratic patient, I'm talking about a standard treatment. You enroll them in a maintenance program and you call it SPIC or SPIC, or supportive peri-implant care. And each time that you see the patient, you need to probe, you need to record BOP, you need to record possible suppression. You need to base on the regularity and frequency. You need to take X-rays. You need to check on occlusion. You need to check on the plaque index. You need to make sure that you review the oral hygiene. You remove the plaque on regular basis, professional plaque removal. And this is the best prevention method to make sure that you keep it healthy. Now, the argument has always been, when it's healthy, why should we do that? So the problem is, unfortunately, we don't have any other measure to keep monitoring the health of the tissues. That's why in a lot of cases, the peri-implantitis gets overlooked. The tissues around implants are very different than the tissues around teeth. We don't have connective tissue attachment, and we have a very light hemidesmosomal epithelial attachment. The probing doesn't really, or I will put it this way, we don't have any evidence to say the probing is going to disrupt this very poor attachment permanently. What's very important is, I always say, probe, but do not use the periodontal interpretation. It does mean that your probing needs to be lighter because we have weaker attachments. probing should be systematic, meaning it should be done over time, so you can see the increasing depth. That's the best interpretation of the probing. And at the same time, what's very important is the inflammation, the early detection of inflammation. Most of the time is not observational. In a lot of times you can detect an early inflammation using light probing around your dental implant. Hence, yes, based on the best evidence so far we have, we need to probe around our implants. Now, in some cases we can't. In a lot of full arch cases, we don't have access to do that. So we will need to use tactile, we need to press on the tissues, we will need to use X-rays, and we will need to probe it if we are taking the superstructure out for maintenance purposes.
Yeah, it's interesting because I'm sort of re-looking at my protocols now, because having done implants for a long time and getting a lot of referrals where they either complete the restoration, they go back to their dentist, or the dentist would do the restoration. I kind of said, no, just don't touch it. Okay, we'll X-ray it at regular intervals. We'll press around the tissues to see if there's any inflammation. But and then I'm talking more about the modern style of restorations and implants, because the older ones where we had the glazed porcelain under the gingiva, there's no hemidesmosomal attachment anyway, more inflammation, probably more need for monitoring. But what we found was, once we had, polished titanium or anodized abutment and a highly polished zirconia in contact with the gingiva, then we got much better attachment, much less inflammation. So in my head, I was like, just don't touch it. Leave it well alone.
Look, the thing is, I wouldn't call it controversial. Within dentistry, there are a lot of things that we are still doing it, and it doesn't make sense. because even when I'm doing the periodontal probing, which I do 10, 15, 20 times a day, we still think, why don't we have anything newer, fancier, more high-tech, less invasive, to be able to detect things or record things. For example, one of the things that some of my friends, they've worked a lot in Michigan University, is using dental ultrasonography. And they've been publishing a lot on this is the future, because you will be able to non-invasively monitor your implants with this sonography. As long as we have nothing else to replace probing, in order to universalize some diagnostic tool, we need to do probing. Now, but everything, every detection method needs education. So when you're talking about the fact that 95% of my cases, if not 99%, are referral cases. Hence, getting them enrolled in a regular SPIC, it's always a challenge.
No, I agree. A lot of the implant complications of my own I may only see them when they come back after 7-8 years. And and in terms of maintenance, obviously we don't want metal instruments around our implants unless you're doing more sort of aggressive debridement. Or are you scaling around?
That's another topic of controversy. Actually, again at EFP, the consensus was, we don't need to use plastic instruments. We can use normal instruments, and that's for probing. But when it comes to plaque removal around implants, the air polishing is the best method.
I think the only other thing with maintenance that we try and hammer home as well is because I think it's the American Periodontal Society said that, you know, a full arch bridge work doesn't need to be removed for maintenance. But in our practice, if it's acrylic particular, it needs to be removed to clean it properly and to assess the abutment. So we regularly remove.
How regular do you do that?
Depends on the patient, but we'd see them at 6 months after after the final review and everything, and the final restoration goes in. We'd see them at 6 months, remove it, check the torque and everything. If their hygiene is good, we might push that to every 12 months. But I'd say the majority of them need it every 6 months in acrylic. Now we're shifting to zirconia.
Yeah.
So now we have a polished surface in zirconia. We're taking them off, and we're finding much less build up.
The intaglio part is much cleaner.
Yeah. So we will then push them, 12 months, 2 years. My concern with those restorations is, one of the beauties of taking acrylic on and off regularly is you're checking the abutment torque every time.
Yes.
Whereas the tendency for zirconia now is, we don't need to take it off, but how are we then checking that the screws are not losing torque? So we're refining our maintenance protocols all the time based on what we're seeing. And some patient, I had a patient in yesterday, full arch zirconia in the upper. She's a chronic bruxer, so I'm taking it off every 6 months because the screws are coming loose. So I think there's no one size fits all with the full arch stuff.
Yeah, I agree. But I agree with you that in terms of regularity or the frequency, you're looking at the risk factors.
Yep.
But I fully agree with you on the fact that these superstructures need to come out. You need to check on the intaglio. You need to check on the multi-unit abutments. Yep. And that way, you're actually preventing further bigger complications in the future.
Yeah, because once those multi-units start coming loose, screws fracture, you got much bigger problems.
Yeah, but it takes a lot of your clinical time as well. So I always call this clinical sacrifice.
Yeah.
Because, but it's worth it.
Yeah, definitely.
It's a good practice.
Yeah. No, I think some of the success I think we've had on long term, especially on the all-on-4, is the fact that most of our patients do come for maintenance because we hammer home the importance of it.
Yes.
Other topic on implant treatment is, because I know you're very heavily involved with the Versa and Densah Burs, and you run regular workshops all across the country and overseas. I've had sort of mixed opinions on Versa and Densah and the use of it. So I wanted to sort of delve into that a little bit because you've got a lot of experience. Obviously, you're teaching. Which applications are you using the Densah Burs for? I know obviously it's a huge topic, but
that's what.
Are you using it for all, i.e. osteodensification, ridge expansion, sinus lifts? What are your main applications that you're using it for and when?
Yeah, I think with Versa is the company. Who's Salah Huwais actually established.
Mm-hmm.
And the Densah are the name of the Burs.
Yeah.
So this is not very important, but it's good to have this differentiation. I got involved very accidentally. I got involved from the initiation of the concept, etc. And it's interesting. Whoever has had controversial thoughts about the Densah Burs, I always say, have you ever used osteotomes? And they say yes, because the concave osteotomes are what we essentially use for greenistic fractures in the floor of the maxillary sinus, and these are concave osteotomes, and convex osteotomes we've always used for low density bone. And when I received that answer yes, I say the Densah Burs are machine-driven vertical osteotomes. So technically, it's nothing controversial. It is useful in the sense that we use surgical machines every day because they adjust stress, strain, time, torque for us. So if we didn't have the surgical machine, we still was using our mallets and hammers and chisels and etc. And this is the same. This is an osteotome which is using surgical machine for the adjustment of the time, the torque. So that's what we call it, stress causing a strain. And based on the effect that's causing, we can use it for some clinical indications. One thing is very important. You can only use the densification concept in the trabecular bone. Otherwise, it wouldn't work.
Yep.
My involvement since 2017, when I started using them, I felt comfortable with them because they are, you've used them.
Yep.
They are very well manufactured drills. And that's why they are more expensive.
Yeah.
And it became a standard of care for me in the sense that regardless of the implant design or the implant brand, or whether I want to do densification or not, I'm always using these drills because they are universal drills. But when I feel like I need to do densification, I have trabecular bone. I can densify it instead of removing bone. I can do compaction autografting. I use it in a reverse mode. And yes, with the transcrestal sinus floor elevation, our classifications, our approach how to tackle the normatized maxillary sinus has changed since we started using these drills.
What's because I think possibly the controversy is through dentists maybe not using it properly, maybe not using fresh drills and causing overheating. And I think, the good point is, I think I've seen dentists just go, we're going to densify everything, and doing it in a dense mandible. It just doesn't make sense from a biological point of view. Do you see that as the main mistakes?
I think so. Look, similar to everything else, you need to learn about the technique, the concept. But before that, you need to know the principles. You need to know about the bone biology, bone anatomy. You need to know about the osteotomy socket preparation. A lot of people, because I've run 36 courses so far for osteodensification, sometimes people ring me and talk to me and they say, I'm looking at different systems for my sinus floor elevations. What do you think? I think I'm going to choose Versa. And I always say this is not a sinus floor elevation kit. So this is a concept, and it's a machine-driven vertical osteotome.
Yeah.
So I think that learning the concept, how it works, and there are two effects of those drills, which one is the compaction autografting, the other one is compression wave. We use these two characters of the drills in our own favor in order to make a hole in the floor of the sinus and then do a hydraulic lift of the membrane.
There was a case actually I saw recently that I think a dentist had sent for some advice, and they'd done an internal sinus lift, and I kind of looked at it and I said, well, what made you do an internal sinus lift here? Because it didn't look like there was any crestal bone, and I think unfortunately that dentist maybe didn't know how to do a lateral window or couldn't do a lateral window. And I think that's, for me, I don't push the Bursa too far. I think I've had some perforations that then are much harder to control. And for me, doing a lateral window, having learnt from yourself many years ago, isn't too challenging. And I quite enjoy it. And it's easy. I can visualize everything.
Look, we have come up with classifications of when to use it, when to not to use it. That's one thing to know. What I'm afraid of is we think there are some tools that we can use them to shortcut our learning process or our treatment processes. In fact, I always say, if you're going to learn about osteodensification and use it to do minimally invasive transcrestal sinus floor elevation for some of your cases, you should learn lateral sinus floor elevation as well.
Yep.
Because you will be using it in some other cases. Through lateral sinus floor elevation, you will learn how to screen sinuses, have to know about the anatomy of the sinus, when to make decisions about to refer to ENT, not to refer to ENT, whether I can do this or it's not within. So unfortunately, as long as we look at this as a shortcut, there's a good chance that we don't succeed.
Yeah, I think that's what I've seen a lot of, is dentists not wanting to refer a case, saying, "Oh, I've got these Burs, I'll just give them a crack," and then the patient ends up with a failed implant and then a much more challenging site to manage.
Yes, and then blame goes to the product. It's just a tool for you in your toolbox to help you with some of your cases, nothing more.
How far are you pushing the internal lifts? Do you have a cutoff point in terms of?
I do have a cutoff point. I cheat sometimes with that cutoff point, but just to make sure that we standardize our teaching process, the cutoff point is anything more than 3.
Yep.
We do the transcrestal sinus floor elevation up to 8. Obviously, more than 8, we don't need to do any type of intervention. But 1, 2, up to 3 millimeter, I still do lateral sinus floor elevation. And in contrast to some of my colleagues in other parts of the world, that they try to say, and I respect their opinion, that this is the new gold standard. I still think the lateral sinus floor elevation is our well-documented, refined, and low complication gold standard technique. And the other techniques are just helping us with reducing the invasiveness of that technique.
Yeah. And I think it depends on your results and what's worked well in your hands. I mean, for me, I had a good run with the the Densah Burs, and then I had a few where we seemed to get crestal bone loss, perhaps from overheating, overcompression. And it was the same with the lateral window. I used to do lateral window, stage it, go back in, place my implant, and then I thought, well, why don't I place the implant at the same time as the graft? But then I had some less than favorable results, and it's kind of like, well, what am I gaining here apart from some time? Why don't I just go back to what worked previously? Yes. So I think your experience shapes you every time.
I agree. Look, we are still working on that. To be honest with you, we just recently finished writing a manuscript for a up to 5-year CBCT follow-up on our cases. Those type of early remodelings in the crestal area, that definitely goes away with refining the technique. One thing is very important. I agree with you about the clinician skills and what works best in your hands. it is what's best for your patient as well. But these days we do speak a lot about PROMs. PROMs is patient-reported outcomes. And the randomized clinical trials that have looked at this technique, comparing it with lateral sinus floor elevation, in terms of the PROMs, the postoperative edema and hematoma, the pain levels, the number of the painkillers taken by patient, as well as we call it OHIP, the quality of life changes after it's all in favor of obviously transcrestal sinus floor elevation. So just looking at the PROMs, patient-reported outcomes, and also what works best for us, we need to make a balance between us. And with refining this technique more and more, what I've learned from some of my colleagues is they try it once, and once it didn't work, we always have a back drawer, huh?
Yep.
They put the case in the back drawer and they close the drawer and never come back to try it again.
Yep. So what are some of the refinements to the technique to reduce that crestal bone loss?
That's the sharpness of the drills. And also copious irrigation. So technically what I always say is whatever irrigation you use for your normal implantology, you need to double it up with this technique. Hence, if you're using the irrigation that we generally use, is we are using the irrigation which is attached to the head of handpiece. And that irrigation, if you look at it, it's only pointing at the drill because it wants to reduce the heating of the drill. We need to have our rotating nurse to do a secondary irrigation to the surgical site. That's one thing that it's very important for us to understand. The third thing is when in this technique we use biomaterial, because this technique uses compaction autografting. You're compacting and autografting the biomaterial into the walls of your osteotomy as well. So when you're finished with your osteotomy socket preparation and also sinus floor elevation, you need to make sure that you clean this off the walls. And in a lot of cases, and this has been a learning curve globally, in a lot of cases that we saw those type of early bone loss around the neck of the implant, as well as loss of integration, we had remaining biomaterial on the walls of the socket.
So you're doing a final cut mode, basically?
No, it's very easy. Once you're finished, just take your syringe and start washing it off.
Okay.
And you will see the pristine bony walls of the socket. And that's when you're going to place your implants. Last but not the least, this is completely anecdotal. It just comes from some experience. Don't try to place your healing abutment, all the magics in one day. Just do your osteotomy socket preparation simultaneous with your transcrestal sinus floor elevation. Place your implant, good insertion torque value, put a cover screw and cover it.
And in terms of burr use, how often should the dentist be changing those burrs?
15 times.
15
times. And I've got a trick because we all cheat, huh?
Yes.
Don't we? I used to fill in this logs myself. I noticed I go to a surgery, you're doing a full arch surgery, you're placing 6 implants and you tick 1. You've used it 6 times. You haven't used it once. So that's why we always have the log, and I'm not responsible for the log. One of the nurses is responsible. So whenever it goes to the red area, they are supposed to replace it with the new burrs.
I'd say that there's many Densah kits out there that have been used a lot more times than that.
You know, that's a common practice for all of us. It's there's a industry trick when you're speaking to manufacturers. Sometimes they receive reports that Mehdi Valizadeh has complained about our products. He's getting a lot of failures. The first thing they always look into is they look into their invoices to see if this gentleman, Mehdi, if he has been regularly replacing his drills or not. That's one of the first things they look into.
Yeah. We always, especially with the sharper drills, you know, the precision and the 2 mil. I mean, with our Nobel cases, we use a fresh one every case. You know, a lot of guys don't. They use them until they're blunt. Whereas that, you know, those, especially the finer drills, are very critical, and certainly with denser burrs, very critical.
That's a very good practice with Nobel, because at the time that I was placing more Nobel implants, we used to do that as well.
Yeah.
The question is, do you have a dental implant in your mouth?
I don't know.
If one day you come to me and I place, you needed an implant and I do, would you rather have a fresh drill or a used one?
Yeah.
So that answers the question.
Yeah. So I think, the listeners out there, change your drills.
Yeah.
Go back to your practice this afternoon and change your drills.
Change your drills.
And with the sinus lifts, I know, it was, I think the lateral wall was something that, I don't know, it scared me a little bit until I started doing it. I came on one of your cadaver courses many years ago, and you taught me very well. And then it just became, not routine, but we do it most weeks. Probably we do some form of sinus augmentation.
Yep.
The graft material of choice, because this is another controversy, different opinions. Whether if we're talking lateral window, we're talking internal. What are your recommendations and what are your protocols for the actual graft material?
The best documented material, When I say the best documented, doesn't mean that the best material. The best documented means the literature that we have available so far in lateral sinus floor elevation is the mix of xenograft and autogenous bone. Xenograft for its dimensional stability.
Yep.
Autogenous bone because of regeneration. Interestingly, when you look at literature, majority of the literature could prove that just using xenograft alone has almost performed the same as a combination. But nothing beats the combination of the xenograft and autogenous bone in the lateral sinus floor elevation. I was just recently reviewing an article which is going to be published in near future, and it was a systematic review of using PRF in the sinus. And every study that has looked at PRF has seen positive effect. So there hasn't been even one study showing no effect or no added effect. So that's something to consider, because PRF is cheap.
Yep.
And it's available. And the more we incorporate PRF into our daily practice, including the maxillary sinus interventions, the better. When it comes to transcrestal sinus floor elevation, the story is completely different.
Yep.
Again, I'm part of a close group of clinicians that over the last 10 years we've led the education with the osteo densification, and we are still having this conversation. What is the best material for this technique? I can tell you after 10 years, this technique is now well documented, well published, is proven. It works. We even have looked into the complication rate. It's not higher than lateral sinus floor elevation. And we looked at its long-term effect in the sinus. There's no negative effects. There is one thing, it's dilemma. What's the best biomaterial to use with it? I have been using a material which is calcium phosphosilicate, Novabone. Novabone so far is the best material intraoperatively. During the surgery, it's very easy to use. It's extremely radio opaque, so you can trace it during the procedure. It's potty, so it helps with the hydraulic lifting. It's injectable, so the transcontamination is easy to use, etc. And it's fully synthetic, so you don't need to discuss about the origin of the...
Yep.
And last but not the least, is fully synthetic, meaning if you accidentally end up perforating, not tracing your perforation, and accidentally propel some of this material into the sinus, it doesn't have the potential to go and block the osteomeatal complex. Yep. So it's safe. But the problem is the remodeling of this material. It lacks dimensional stability, meaning it goes through some unexpected remodeling. And that's why when a sinus is too wide or too large, it doesn't become the best biomaterial that we need. In contrast, allografts, they remodel perfectly. Allografts. And I call allograft the best biomaterial for this technique in post-operatively, but they don't have the advantages, the intraoperative advantages of the Novabone. And in terms of xenograft, we don't like using xenograft with this technique because we don't like to take bone fillers and compact them into the walls and push them towards the membrane.
Yeah.
And this increases the risk of perforation. And when you push xenograft into the sinus, then it's out of your hands.
Yes.
You will need to get what we call it professional help.
Very interesting. Yeah, I sort of followed your advice on the xenograft for the lateral walls and did actually do some cases with allograft, but they didn't seem to hold up quite as well. They seemed to resorb a little bit more. I don't know whether that was just the case or not. So I've kind of stuck with the xenograft mixed with autogenous because, whether that's evidence-based or not, it makes sense to me to have those cells in there. But the internal lift, I think the issue, the concern, because I was doing them with xenograft was you got to make sure it's not going to go anywhere else.
Exactly. Exactly.
Very good. Great points. Education events that you've got coming up, Mehdi, because I know you obviously run the Densah courses. Have you got many of those coming up this year?
This year, we will have 2 remaining courses. Around 3 years ago, globally, there was it seemed like there's a need for a complementing course.
Yeah.
So that's why, as if you start using the technique, the concept, and you come up with some problems, questions, etc. Hence, we started running a course that we call the Advanced Osteodensification course, or what we call the Level 2 course. And I do it once a year. Last year, we ran it in Gold Coast. And this year, we will be running it at APS conference in Melbourne. So it'll be one of the pre-conference workshops.
Fantastic.
One big I was talking to you about is the big conference is our Australian Society of Periodontology's federal conference, which is going to happen here in Perth in September.
24th to the 26th?
26th of September.
Yep.
So this is something that every 10 years' time, because the ASP conferences, they rotate.
Yep.
And every 10 years' time, so the last time we had it here, one of the states actually skipped it 2 years ago. So we had the last one 8 years ago. Dr. Fritz Haitz was the chair of that conference. And we will be having it this year in Crown Towers, Perth. What was important for us was to make sure that we don't follow the usual trail of implants. So we have a good mix of interesting perio. The reason I say interesting perio because the people who are going to come to Australia for the first time, they're on top of their games globally. Interesting perio, some implant, some endo perio. We have a gentleman coming from Japan, which is a master of autotransplantation. You know, it's that there is a little bit of, if not too much, interest in autotransplantation these days. We have PerioPros, and and also we have specific workshop and lectures for our hygienists.
Okay, great.
I actually was with Ignacio Sanchez, who he's from Madrid, just 2 days ago, and he will be joining us here in Perth, and he's going to run an implant maintenance program workshop for the hygienist only. So in that sense, I find it very inclusive. I know I'm very biased, huh? It's like this type of conferences become, you have the same feeling with your courses. They become your baby.
Yes.
Huh?
Yeah.
You're biased, but at the same time, you feel like, people shouldn't really miss it because it's an opportunity that you don't get to have this opportunity all the time. So I'm inviting everyone who they need CPD points, they want to connect, they want to mingle, they want to come and see all these companies who they are going to have booth and stands in the exhibition, and join us for that 2-3 days. I'll be more than happy to host them there.
You know, I've had a look at the lineup. It looks like a great event, and nice to have, again, we don't get a huge amount of the big conferences in Perth.
Yes.
So it's great for us, and,
Yes.
and those who haven't visited Perth, they definitely should, because we're biased. We think it's the best place to live.
The best place to live. Yeah.
And the fact that the mix looks good as well. Like, you know, the mix of perio. I noticed there's some peri-implantitis management stuff in there. You know, I think there's some stuff on systemic health as well, which is very important. I was speaking to Max Casado in Bangkok on the last podcast about systemic health and implant healing. So it looks like a fantastic event, and I'll definitely be trying to attend if I haven't got travel commitments myself. And I might also try and steal a couple of your speakers for another podcast maybe. And I noticed Mike Dinesh is over, so I'll be giving him a ring.
Actually, we are very happy to have Mike as well. Yes.
Yeah, Mike's great.
Mike is great.
Fantastic. Well, thanks for coming on, Mehdi. There's a number of things I could ask you. Maybe we revisit this another day as well, and ask your topics. I know you've got a lot of experience with peri-implantitis management and those things as well, which we get asked a lot about. But appreciate your time. If people want to find you, you are Dr. Mehdi Valizadeh, Periodontist on Instagram, and your practice is Vision Periodontics in South Perth. And then obviously those who are interested in coming to the ASP conference, I think there's links on your Instagram page, and they can just Google the.
Or
online.
Also they can go to aspconference.com.
Yep.
Or they can visit ASP Federal's Instagram page.
Great. Well, we'll put the link on Spotify as well.
I appreciate that. Thank you.
Thanks for your time, Mehdi.
Thank you for
great
having
to see
me.
you, and we'll have to catch up again soon.
Always good catching up with you. Thanks,
buddy. Cheers.
Take care.